Well, hello. Thank you for joining us for the first ever Medicare Education Expo. You might have tuned in for one or more of our earlier sessions today, but for some of you, this may be the only one that you registered for. So either way, we're glad you're here. I do want to give a little plug quickly for our training center area of our website. This is where we will post the event materials for most webinars, and we do that about a week in advance. So if you want to download a copy of a slide deck, then you can find it on our live events page. Now, I said most because for this event, a copy of this presentation was sent yesterday or today, if you registered today, to the email that you used when you registered. If you don't see it, either you registered just a couple minutes ago, or check your junk or your spam folder. But don't be concerned with trying to find it now. You don't have to have it in order to participate. The live events page in the training center of our website is also where you can find out about and register for upcoming educational events. The recordings of this and other live webinars will be on our website in a different place. It's called our Encore Presentations area. And we usually have them there for about 60 to 90 days. They kind of rotate on and rotate off. You can also find them on our YouTube channel. Today, we're going to have you email any topic-related questions to our Same Education mailbox. Due to the volume of people that we have registered for the event today, we just thought instead of running the risk of missing it in the chat, we would have you email it to us. We hope you'll take the opportunity, whether you're listening to this live or as a recording, you'll take the opportunity to give us your feedback by taking our survey. The surveys are what gives us insight into how we're doing, but it also gives us a window into the type of education that you want and need. And we want to make sure that we look at that because we think we're giving great education, but if it's not helpful for you, we need you to let us know that. You've seen this disclaimer before. This is to inform you that the information we're providing is as accurate and complete as it can be to the best of our knowledge. Medicare is a fluid program. It changes often. And the federal regulations are, of course, going to take priority over anything that's presented today. And then finally, CMS does prohibit the recording of this presentation for profit-making purposes. We're recording it for you, so there would be no need to do that, and that does include screenshots and such like that. This slide contains acronyms. These are acronyms that I specifically used in the presentation or that I know I'm going to mention. Medicare has acronyms for everything, too many to try to memorize, and they can get pretty wordy to use on every slide. So instead, I'm just going to give you a list here that you can look back at. Some of these you're familiar with, some of you may not be as familiar with them. Now let's find out who you're going to be hearing from. I'd like to introduce you to our panel today. If you participated in other sessions earlier today, you may have already been introduced to some of them, but this might be your first and only session today. So I want to give you a chance to put a face with a name and a voice. You've already become accustomed to my voice. I'm Aline Sigler. I'm going to be your moderator for today. This slide contains a little bit about me and my Medicare experience. This lovely lady is Karen Curtis. She brings a vast knowledge of the Medicare program and her background in a variety of different positions. Her experience, like mine, began with keying paper UB92 claims, lots and lots of UB92 claims. And I know this because she and I were in the same training class back in 1997. She actually started about a week before I did. Next, we have Dr. Joelle Vlahakis. She's one of our contractor medical directors, and it truly is an honor and a privilege to have her partnering with us today. Mary Sue Gardner is one of 2 nurses on our team. Her clinical expertise and years of experience are truly a welcome asset to provider outreach and education. Leanne Foster is up next. If you've had the opportunity to hear her present and learn from her, you know what I mean when I say that her proficiency and enthusiasm is off the charts. Leanne has also graciously agreed to help me out behind the scenes by placing some things in the chat for you and making sure everything behind the scenes runs smoothly for me. So I want to thank her for her help today. Rounding out our panel of experts today is Tom Ryan. He wears many hats on our team, supporting our team and providing education with confidence that's next level. So that's our panel today. I want to thank you all for being here today. And now let's talk about the purpose of this session and the Medicare Education Expo overall. And the reason for that, our thought process is to increase your knowledge of how Medicare develops and applies coverage policies. We're going to begin with an overview of the day and the different sessions that were presented. We'll take a look at the questions that were submitted during your registration, and then we'll take as many questions as time permits. We'll finish up our time together with a couple reminders and some updates, so you'll definitely want to stick around until the end. The Medicare Education Expo is a day dedicated to providing extensive education in a virtual format on a single or related topic. We chose Medicare policies with a focus on national and local coverage determinations. And the fact that almost 1,700 people registered tells us that it's a topic you're interested in hearing more about. We created 5 separate sessions to choose from, depending on your interest and availability. So whether this is your 5th or your 1st session, we hope that it's been beneficial for you. We started off this morning with an introduction to the world of Medicare coverage determinations. Karen Curtis led this session, and among other things, she reviewed how NCDs and LCDs shape reimbursement, clinical decisions, and compliance with Medicare regulations. Our second session focused on 10 things that we want you to know about LCDs, including the creation and approval process. If you missed that one, you'll definitely want to review the encore when it's available. Dr. Vlahakis and Mary Sue led an informative and interactive class with that one. Leanne Foster facilitated our 3rd session, which was all about navigating the Medicare coverage database. She shared helpful tips and tricks to enhance the user's experience. Those tips are so helpful. By now, you've probably realized that when I introduced our panel, I did it in the order of appearance based on the day's schedule. So kind of like a movie credit, because they're all rock stars, and that's why. Tom Ryan hosted session 4, which was all about who to contact in different situations when you have questions, need clarification, or you want to request a reconsideration of an existing policy. So what can you expect from our Q&A panel session this afternoon? So let's set some ground rules here. First of all, questions must be directly related to the education sessions and the NCD and LCD policy process. Many of you submitted questions during the registration process, and those have been downloaded by all of the presenters. If you have a question that was not submitted during registration, those can be sent to our education mailbox at the address listed here. To avoid duplicates, please only send new questions. So if you send a question and maybe the presenter ran out of time and didn't address it, rest assured we still have it and we will provide an answer. If your question pertains to a specific session or you'd like it posed to a certain presenter, indicate that in your email. To help consolidate things and ensure that nothing falls through the cracks, please refrain from emailing the presenter privately. One final note, we are not able to answer claim-specific questions or questions specific to an individual code or policy. For our panelists, please remain on mute unless you're speaking to help minimize background noise. During registration, we asked sorry, I'm getting tongue-tied. We asked, what one question are you hoping to have answered during this webinar? Or what questions do you have related to Medicare policies, meaning NCDs and LCDs? Your response was amazing. We got a list of really great questions, so we want to thank you for that. And don't worry if you didn't submit a question. Many of you said, I'm not sure, none, everything, NA, or I'm here to listen and learn as much as I can. And those are perfectly acceptable responses. We have various levels of experience on the line. Some of you might be brand new to the Medicare program or brand new to learning about Medicare policies, and some of you may have been doing this for years. Sometimes listening to other people's questions is an education in itself, so soak it all in. Some questions were very similar, so I may have combined them, condensed them. I also may have paraphrased your question for clarity and conciseness. I tried to group your questions together in a way that made sense for you and for our panel. So they're not necessarily in the order in which they were received. So let's get started. Let's look at these questions. I'll address the first one. What reference material is used to create an LCD? As a MAC, we utilize various reference materials when we're creating LCDs. The first one is clinical evidence. We review clinical evidence, which includes peer-reviewed medical literature like published original research in journals, randomized clinical trials, and systematic reviews. We also use Medicare's statutory and regulatory framework. LCDs are based on Section 1862A1A of the Social Security Act and Chapter 13 of Publication 100-08, which is the Medicare Program Integrity Manual. Another item is clinical guidelines and consensus documents. We consult with clinical guidelines, consensus documents like practice guidelines from professional organizations, and expert opinions when available and applicable. We may also consult with medical associations, healthcare professionals, and subject matter experts, such as those on the Contractor Advisory Committee, also known as the CAC. During the development process is when we take that into consideration. Public comments and stakeholder input is also an important component and considered reference material. As you may have learned earlier today, LCDs are subject to public comment period, during which stakeholders can provide information related to the proposed LCDs. So I want to thank you for that good question there, Candace, that got us started. Now on to the next one. This was received a couple different times in similar ways. Shelley asked, does an NCD supersede an LCD? And Diane came in with something comparable. She said, if there's a national coverage determination and a local coverage determination for a code, which one do I follow? So I'm going to pose this question to Dr. Vlahakis, and can you help us out with this one?
Sure. So national coverage determinations always supersede a local coverage determination. In an idealized world, there shouldn't be a conflict there, but the national coverage determination always trumps. That's in our hierarchy of regulations, it is higher.
Great, thank you. Thank you so much for that. Sometimes things are clear to us, but they're not always clear to someone else. So we do thank you for those questions. I'll actually be posing the next few questions to you, Dr. Vlahakis, so if you want to keep your finger on the ready of your unmute button, we do appreciate you being here today. Can other MACs LCDs be used for claims consideration in the absence of an NCD or a WPS LCD?
So the short answer to that is no. A local coverage determination is precisely that. It's local. It's specific to the region of the max coverage area. Obviously, in the absence of an LCD, we would be utilizing our claims data to follow things. And if at any point we determined that we also needed a WPS and LCD for that specific scenario, it's very likely that we would be utilizing some of the other MACs to help us construct a new policy. And that might be in a multi-MAC policy, or it could be when they begin their reconsideration process. And it could also be at a time when we simply determined that, yes, we could use that LCD as well.
Thank you so much. And that was a perfect segue into our next question, actually, because that has to do with multi-MAC input. Are MACs trying to create more multi-jurisdictional LCDs?
So I wouldn't necessarily say that we're trying to do that. Obviously, it is something that external stakeholders appreciate. I think many of you appreciate when we have language and coverage that's more similar than dissimilar. It tends to be less confusing, and you simply have more confidence that it's based upon the evidence. We went over in my presentation some of the advantages of a multi-jurisdictional LCD. You know, working on them together, it creates an opportunity for MACs to build relationships with each other. It gives us an opportunity to share expertise, share subject matter experts from each other's CACs, combine resources with research, and even do some of our evidence-based CACs together. So those are some real advantages. The disadvantages are simply that sometimes it takes a little longer to create these. And one of the things that's nice about an LCD compared to, say, an NCD or a multi-jurisdictional LCD is that when you do it singly, you're very agile and it's a little easier to make changes, amend them, and respond to reconsideration requests.
Absolutely. Thank you so much. And then the last one on this slide, does WPS assist CMS in creating NCDs, Dr. Vlahakis?
So there's certainly a lot of communication between CMS and the MACs, and there are various ways that that can happen in in-person meetings and virtual meetings and the like. Generally speaking, CMS doesn't need us necessarily to create NCDs. They may reach back to us, say, for the inspiration to even create one if they're getting multiple requests or feedback from various MACs. That might inspire them to create an NCD. They may also reach back to WPS if we happen to have some subject matter expertise or they know it's something that we've created or worked on previously to assist them in forming that up. It's a very long process to create a national coverage determination, and while I'm sure there's a little bit of back and forth, officially they're able to do quite well on their own.
Thank you. Let's see what else we've received here. I realize this subject might have been sprinkled within a couple different sessions today, but Dr. Vlahakis, what is the most effective way to advocate for changes to current policies?
We did talk a little bit about this in my session, but just to reflect on it, you know, there are a lot of potential entry points for external stakeholders, providers, and CAC members, especially to have their say in changes for current policies. Probably, to me, one of the most effective ways is the reconsideration request. I mentioned that LCDs in their ideal world should be dynamic documents that has back and forth, that allows us to extend coverage or change coverage to reflect medical advances and improvements in technology. I think that openness is really important. And I think also one of the things that I didn't talk about today was an informal meeting. Sometimes people who aren't sure they have enough evidence to warrant a full reconsideration request can ask us, the MACs, for something called an informal meeting. And in this way, it's just a listening session for the MACs to hear what they already have, and then have a little back and forth about what their next steps might be. One of the things that someone asked, which I thought was a really thoughtful and good question, is, you know, how often are you looking at LCDs and reviewing them? Officially, we do so every couple of years. And when you think about it, 2 years used to seem like a really long time, but in medical circles, that's not super long, and things can change very quickly. So again, we really rely on other folks to let us know. And in this way, we don't necessarily have a specific window to advocate for changes to current policies. Certainly, if we have a draft of a new LCD and it's an open comment, that's the best way to advocate for changes directly onto the policy. But if it's a policy that's already in place, the reconsideration request is really the best way to go. And that doesn't require a window of time specific to the process.
Wonderful, thank you. Next question. Is a facility or provider required to meet the indications section of an LCD, or is it sometimes state specific? And they gave examples of service accreditation, staff certifications, and dosage or medications listed.
So is it this or is it that? Yes, it's both of those things, and I don't mean to be cagey about this. It's just that it kind of depends. So if an LCD is specific about the provider or type of facility, for example, an independent radiology center, it will list all of those requirements. If it suggests that they need to simply follow state mandates, then you can often depend on state certifications, etc. But typically, I know often people are a little dissatisfied when they're looking because it can be state specific and feel a little ambivalent. And trust me, the other CMDs and I answer these kinds of questions all the time because it is confusing and it sometimes is very specific to the situation and context and state.
Thank you. The next one has two parts. What is a provider's general success rate on getting a policy updated, and how long does it usually take?
So I don't know what the batting average is for most folks. I know that we take each of these very seriously and we spend a lot of time on them, and we want to make sure we have the best policies possible. And again, the only way for us as a MAC to make sure we're doing that is to listen to our external stakeholders. It generally takes somewhere around the 12-month mark, anywhere between 6 months and 2 years, kind of the same as developing a new LCD. And you all know this from your own life. Sometimes it's easier to start over again from scratch than to try to build on something you already have built. And so sometimes that goes back and forth for us as well. We try very hard to make sure that you know what's happening as we go along, but the success rate I really couldn't comment on, simply because I don't know that we've ever taken that measure. Again, we just take each specific request in context and try to make sure that it gets moved forward to enhance the care of our beneficiaries.
I understand, and thank you for that insight. Last one in this section, and then I'll let you have a break, Dr. Vlahakis. But again, thank you for your help and working with us today. How can physicians request more engagement with WPS?
Well, I tell you, we're always eager to have additional CAC members. In addition, as a MAC, we love being asked to help collaborate with other specialty societies, other medical societies, state medical societies, etc. I think those conversations and those relationships, I know I sound very old-fashioned, but I think those things are really key. One of the things we've noticed is as we've grown, there are a lot more CMDs covering the US. There's a lot more of us because there's a bigger population. So some of us are newer. Some of our physicians, venerable physicians, have retired, but the same is happening for physicians on a national scale. We need physicians that are of different backgrounds, not just different specialties, but also different life experience. Do you practice in a rural environment? Do you practice in an academic environment? What's your lived experience, and how does that impact how you think about medicine? We're very much interested in having all sorts of folks from all sorts of backgrounds on our CAC, and I think ultimately, again, that will help us write better policies and make sure that more voices are heard.
Thank you. Thank you so much. I told you we've gotten some great questions. How often are LCDs updated? Mary Sue, would you like to respond to this one? I know Dr. Vlahakis mentioned it just a little bit ago, but what do you have to offer for us?
Sure, Arlene. They have to be updated or looked at or reconsidered every couple of years. However, it's on a rolling basis, so not necessarily a fixed schedule because of requests for reconsiderations and stuff like that come in. You know, policies are always being looked at and considered. So while they have to look at them every couple of years, we find that the majority of them are actually looked at, you know, in less time than that.
Great, thank you. Leanne, I'm going to reach out to you next. You talked about navigation in your session. This next question says, what's the easiest way to find billing articles and diagnosis spreadsheets associated with an LCD?
Sure, Arlene. The easiest way is really to look at the MCD. I would recommend searching by either the keyword, or if you're looking for something that is specific to a diagnosis code or a CPT code, search by that. You'll find the LCD, but you want to also look for those companion billing and coding articles. Those companion articles are going to contain that information. But you'll search those very much the same way as you do an LCD.
Thank you. Thank you so much. I'm going to flip back to Mary Sue for this one. Why do some NCDs not have a list of covered diagnosis codes?
Well, that's a good question, Aline. NCDs are developed by CMS. So that's kind of a CMS thing to answer. But depending on the national coverage determination, it may not be diagnosis specific. So it may not be dependent of a diagnosis. But no, things like the NCDs for laboratory, those are very much diagnosis dependent. And there's actually laboratory NCD manuals that you can look up all the different labs as well. So the long of the short is that's a CMS decision, not a WPS decision. But if the service is not really diagnosis dependent, CMS probably won't list any diagnosis codes.
Right. Thank you. Thank you so much. Another one that points to reviews, so I'm going to stick with you, Mary Sue, and your expertise. How is compliance with LCDs monitored?
Well, there's several ways that compliance is monitored. We could have audits, edits in place based on local coverage determinations. There are some automated edits that are in place that if you bill a certain code combination and it's specific to this, an LCD that we have in place, your claim could process and maybe pay or deny based on those code combinations hitting the LCD. So that's one way of us looking for compliance with LCDs. We can also automatically or manually review providers. When we do our data analysis, we're going to look at providers for certain services, and including services we have local coverage determinations for. And we're going to see if we have a large provider base that are billing those types of services. If that is something we find, quite often we have providers billing in, and quite often there's issues in, we may choose to do targeted probe and educate reviews based on that service. And then if we do that, we will use those LCDs and the criteria listed in the LCD for those review purposes. So that kind of takes us to the last question that you have on the screen as well, is how does a reviewer decide what criteria from the LCD might be missing from documentation that allows for a full denial of a claim? And what I'm here to tell you is if we have a local coverage determination on a service, on an item or service, and we have decided to manually medical review that service, then our review nurses are going to use all the coverage criteria and documentation requirements that are listed in that LCD, listed in any other CMS manuals. And that's what we will use to determine if you have indeed met the criteria for coverage. So if it's listed in an LCD as a component of coverage criteria, that means it needs to be reflected in your documentation. If it's listed in your LCD as a documentation requirement, again, that means it needs to be listed in your documentation. And then we're going to make a determination based on, did you address these things? Did you meet the coverage criteria? Did you meet the documentation requirements? Did you follow everything in those requirements? And did you provide a medically necessary service to that beneficiary on that day of service?
Great. Thank you so much for wrapping that up on this set. One more for you, Mary Sue, for now anyway. When a claim denies for an NCD or LCD, but you can't locate it, what's the next step to further research?
Okay, so Generally, if your claim was manually medical reviewed, the information regarding that medical review and those findings is going to be listed in our provider portal. So if you have access to our provider portal, or someone within your facility or office has access to the provider portal, they can actually log in and look up the actual claim determination decision. And it will point you back to what local coverage determination was used in that finding. If all else fails, it was an automated denial based on a local coverage determination, and you're having issues identifying what local coverage determination it went back to, your best bet then, since it's claim specific, is to contact our customer service department, because they're the ones that can actually look up your claim and help you find that information.
Right, right. All right, thank you. How do you appeal LCD or NCD denials? Tom, can you help us out with this one?
You bet. So a couple of things come to mind. When you're talking about appeal, I'm going to assume that you already have the claim in the system and it's denied. One, check to make sure it's an actual LCD or NCD denials and they have appeal rights. Second, follow through with the appeals process just like any other claim denial. You may need to reference, though, within the LCD or NCD what you're questioning, why you think it shouldn't be denied based on that. There's also another factor. This is not a reconsideration. You actually heard Dr. Vlahakis talk about that. So if you're trying to do a claim denial, but you want an overall change to a policy, the appeal process will not do that. You do want to do the reconsideration. The appeal process simply starts at level 1 and works through level 5, just like any other claim appeal. In level 1, you want to state why you disagree with the appeal, what part of the LCD or NCD you feel like might have been misinterpreted, not understood, what also happens. So that's what you're looking for when you're doing the claim appeal.
Thank you. This next one is similar in that it mentions appeals, but it also mentions corrections. How to file a corrected claim and or appeal. Tom, can you give us some advice here?
Sure. So first of all, if it's denied and it's denied for an appealable reason, we always recommend that you file that. Now keep in mind, a corrected claim is a little bit different. If you're talking about a UB04 or 837I, you're going to want to enter direct data entry and actually correct the claim within the system and then put it back through. Now, I'm not sure if that's the person that we're talking about, or we're talking about someone that files on a 1500 claim form or 837P electronic transaction. In which case, if the claim is denied and you need to do a corrected claim, note I said if the claim is denied, then you can simply submit the corrected claim. Because it's denied, it's not going to do that. If you're talking about an appeal, then that's where you want to enter into the formal appeals process, starting with the redetermination at level 1 all the way up through level 5, federal district court. With the corrected claim, it is different than an appeal. Which one is best? I will tell you, if you already have it in the system, follow the appeals process. In many cases is the best. If it is unprocessable, which is the 1500 or 837P terminology, or return to provider, which is the UB04 or 837I terminology, those ones you do either need to correct the claim or send in a brand new claim to get that through the system.
Great, thank you for that. This last one here is also related to appeals, Tom. Can an LCD help me when submitting redeterminations?
Absolutely, an LCD can help you 100% when considering a redetermination. One, if you look at an LCD and you're looking at in there a section, so they're going to have an area that defines for you what the benefit policy manuals were, what the CMS sources were, all of those things. Start that way. So if you feel like it's that, might not be the exact LCD for you, it might not be the exact information that you need, but you're able to look at it and go and say, oh, I see, this is actually part of this benefit policy manual. Oh, here's some claims processing information. That's all going to be within the LCD to help you out. So there's going to be a huge chunk of it that's there for you, but you have to do the research back. So I'm going to recommend going to those reference materials, researching it back, grabbing what you need out of there, and then when you write the redetermination, incorporate the information from the reference material, where you found it, what you're using, and how you're interpreting it, so that we understand what you're doing.
Excellent, excellent advice. Thank you. That was the last one in that set. So this next one is interesting. What exactly does lack of info needed for adjudication mean? I'll take this one here because I found it interesting, and so I wanted to learn more about it too. I'm going to make a couple assumptions here. I'm assuming that you're probably talking about claim adjustment reason code CO16. That's a common one that we see in this situation. You're going to see that on your remittance advice. The definition of that is claim or service lacks information or has submission billing errors. So essentially it means that there's not enough information available to make a formal decision or resolution. So a claim might reject or be unprocessable because it's missing key information like patient demographics, correct CPT or ICD-10 codes, the date of service, or supporting documentation like physician's notes or test results. The CO, which is a group code, stands for contractual obligation. And so for those of you who might not be aware, that means that the provider is responsible for the omitted information and the patient cannot be billed. Now also look for remarks codes. Along with the denial code, remark codes might be included and they might offer some even more specific details about the missing information. So thank you for that question because I learned a lot from that one. Next one. When submitting a replacement claim, what does it mean when the status is inactivated? So based on the details that were given, again, I'm making some assumptions. I'm assuming that this is a Part A provider and that by replacement claim, you mean an adjustment. Claims that are returned to provider, we call that RTP in the Part A world. So it's RTP'd for correction, and it's not addressed and resubmitted, so it's not corrected within a certain amount of time. That claim might be inactivated by the data center. So rather than just have it sit there taking up space, the data center might inactivate it. Now, since RTP claims don't purge from the FIS system, if you're not familiar, FIS stands for Fiscal Intermediary Standard System. That's the Part A claims processing system. They don't purge from the system for 180 days or more. So there is a feature built in within FIS that allows a claim to be suppressed. This could be helpful for RTP claims that don't need to be resubmitted and are filling up unnecessary space in your claims correction menu. With that being said, though, this action is permanent. You can't reverse it. So if you inactivate a claim, it essentially doesn't exist anymore. So we want you to do it with caution if you do decide to do it. If you suppress a claim, then it's going to move to status location IB9997, and that I stands for inactivated. So you can't adjust these claims. You would have to rebill a new claim. So I hope that helps with that question. Next question. Please go over the steps of how to submit a replacement claim for Part A. Do we override the document control number and add condition codes? Which DCN, document control number, do we use? So I'm also going to take this one because it's kind of related to the previous question. Again, I'm assuming you're talking about an adjustment since you mentioned the claim change reason codes by way of the D4 and D0 condition code. I think it's just a verbiage difference that I'm not used to, that term replacement claim. So first thing, if your claim is denied due to an LCD or an NCD, you want to research the actual reason the claim is not paid. That's going to help you determine, and Tom mentioned this, whether you can adjust it, resubmit it, or you have to submit an appeal. Usually claims or lines that have a denial where medical necessity is in question have to be appealed. So let's pretend that you check the claim and yes, it is something you can adjust. You're going to do a debit credit adjustment off the most recent action of that claim. So what I mean by that is if the claim came in and processed, and that's the only action that was taken, you're going to set up the adjustment using the document control number of that original claim. Now, if the claim has already been adjusted one or more times, you want to set your adjustment up off of the most recent action. I hope that makes sense. For specific details, consider calling our customer service area. They can look at the claim history with you. They'll be able to give you some more specific advice. Also, look at the direct data entry DDE manual on our website. It's going to walk you through the things that we just talked about, suppressing claims and step-by-step instructions on how to adjust a paid claim. On our homepage, look at the right side. We have a box that says quick links and the DDE manual. You can get there from there. All right, moving on here. Made it to our last set of pre-submitted questions. Who would we contact if we discover a Medicare Advantage plan isn't following NCD or LCD guidelines? I'm going to reach out to Karen Curtis for this one. Can you help this person?
Sure. Well, WPS does not handle Medicare Advantage plans. Those are through private insurance companies. So unfortunately, we do not have representatives who are able to help with this issue. Now, what you can do is you can contact the CMS regional office that has jurisdiction over the state where you are located. I am going to add a link into the chat right now. This is where you're going to be able to find a list of the regional offices. It's going to give you a link to the contact for that office, and it's also going to give you the states served by that region. So hopefully that'll be something that'll help you out with that issue.
Great, thank you. The second question here asks about preventive services, and they give the example of PSA tests. Several of them have national coverage determinations associated with them. How does Medicare determine which tests or services to pay for, the age and frequency limits? Karen, would you like to respond to this one also?
Sure. Now, I took this question and I looked at it by the example that was given, which was a PSA test, and it actually was a really good example because there are a lot of agencies involved. So I'm going to start with the U.S. Preventive Services Task Force. Now, this is a team of national experts, and they come from a variety of different fields. They look at services and they make evidence-based recommendations regarding preventive services. So each service is reviewed to determine if there's evidence that the service is effective. They also look at the balance of benefit versus harm. So, you know, does the patient, you know, if they get this service, does it benefit them more or does it cause more harm? The service is then assigned a letter grade, and that indicates the strength of which this group would recommend the specific service. And a lot of times when they give these recommendations, they're going to include an age range that they think would most benefit from receiving the service. Now, I bring this up because their documentation could be used when developing a national or a local policy. So now if you take that PSA test and if you go to the Medicare coverage database and do a search for it, you're going to find both an NCD and there's multiple LCDs out there. Now for an NCD, those are determinations that are made by experts within CMS staff.
For WPS, our LCDs are joint efforts between policy clinical staff and our contract medical directors. So they're the ones that come up with those policies. Now, both NCDs and LCDs are developed by looking at medical documentation, and this is going to include peer-reviewed literature, studies, articles. So that's why I kind of brought in the U.S. Preventive Services Task Force, because they do provide documentation that could be used. And I will give you a link to the U.S. Preventive Services Task Force. You can go out there and you can do a search for any service or items, and it will show you the recommendations that are out there. So I hope that's helpful.
Awesome. Thank you so much. All right, moving on here. I'm nervously watching the clock here. How do we know if the service requires a patient to be in a clinical trial? I'll take this one. In a nutshell, to find out if a specific service requires a Medicare patient to be enrolled in a clinical trial, you should first check the relevant NCDs on the CMS website. As you know, NCDs outline whether Medicare will cover a specific service or technology on a national level according to CMS. Some NCDs may specify that coverage is only available within the context of a clinical trial, indicating a coverage with evidence development, or CED, of course it has to have an acronym, is required. If the service is covered under CED, then the service will require participation in a clinical study. In Leanne's session, we learned that the CMS website contains the Medicare coverage database, where you can search for NCDs related to the service in question. You can also check clinical trials, all one word, .gov, to see if a clinical trial is actively recruiting patients for the specific service. This is a registry and results database of publicly and privately supported clinical studies. The site also provides information about clinical trials, including eligibility criteria, which may indicate if Medicare coverage is contingent on trial participation. Thank you for that question. And then the last pre-submitted question that I have for you today is, are LCDs binding legal documents? Short answer, no. Longer answer, LCDs are policy decisions regarding whether a particular medical term or service will be covered within a specific geographic jurisdiction. While they act as guidelines for coverage decisions, LCDs are not legally binding documents in the same way as laws or regulations. They're not developed through the formal rulemaking process that's required under the Administrative Procedure Act, or APA, which is the standard process for establishing legally binding rules and regulations. The Supreme Court case, Azar versus Allina Health Services, affirmed that guidance documents like LCDs that have not gone through the formal rulemaking process have no force or effect of law. So while LCDs are important guidelines in Medicare coverage, they do not have the same legal weight as official laws or regulations. Now that brings us to about 5 minutes before close time. I do have some updates and reminders that I need to share with you. If you have a question that was not addressed in this session or any of our sessions today, we will provide answers to everyone that attended the live event. So rest assured we will get to those questions for you, and we thank you so much for sending those in. So I'm sorry that that's all the time that we have for now, but we're also going to give you the opportunity to submit additional questions. I'll give you those details in just a moment here. But I do have a couple of news items for you. As our first Medicare Education Expo comes to an end, we're already looking forward to the next one. You'll want to watch our e-news and our Facebook page for the official announcement, but for now, circle the date, mark your calendar for October 14th. That will be our fall edition, trying this Medicare Education Expo. I also want to make you aware of a process change for our customer service area. To better serve our providers and streamline call handling, the Provider Contact Center will accept one NPI and PTAN combination per phone call effective August 4th, 2025. And this change is being made to improve call efficiency, decrease call wait times, and ensure quicker resolution of your inquiries. So we just wanted to announce that and make you aware of that change. In a few moments, you're going to receive an email to thank you for attending. I don't want you to delete it without reading it. Again, maybe this is the 5th session you've attended today, but some of you, this is your first one ever. And so we need to explain this to you. This email contains your certificate of achievement. It's going to look similar to what you see on your screen here. It has your name, your contact hours, if you need to turn it in for credit toward continuing education units. If you don't see it in the next 5 or 10 minutes, check your junk or your spam folder and make sure to add the WebEx email address to your safe sender list. For those of you who are listening to this class as an encore, we definitely thank you for your interest in our education, but there's no way for us to verify your attendance, so a certificate wouldn't be possible. As promised, if you think of a question later, you have 1 week from today to submit a follow-up question. Send them to our same education mailbox. Put today's date and Medicare Education Expo in your subject line. We will compile all of those questions, send them out to everyone in attendance on the live session today. Please take a few minutes to complete a survey about this course. Tell us what you liked, what we could do better. Give us suggested topics for future education. If you have a topic that you think would be conducive to this large virtual format, we'd love to hear about it. You have a few options depending on what your preference is. You can use the link that Leanne's putting in the chat. You may have already done that. Or when you exit the webinar, you're going to be asked to go to an external site. And that external site is the CMS Qualtrics page for the survey. And the message is going to look similar to this screenshot here. It's going to have the triangle, it's going to have the blue continue button, and if you press that blue continue button, it will just take you to the survey. We don't have access to change the verbiage on that notification, and so if it's the first time you're seeing it, you might wonder what it is and choose to ignore it, but it is safe. Just for the survey, and that survey is so very important to us. If you're listening to this class as an encore, you're going to get a box that's going to appear, it's going to look similar to the other screenshot here with the finger and the stars. And you can use that to link to the survey, or you can scroll down in the description for the video and find the link to the survey there. So however you do that, let us know. Let us know if you'd recommend our education to other people. How likely are you to attend other events that we host? Those items are what gives us insight into how we're doing and the types of education that you want and you need. Just to kind of let you know that we do look at those surveys and we take your feedback to heart. We're committed to making changes to improve your education experience. We have a couple examples for you. Based on survey comments, we've incorporated chapters into our YouTube channel, so you can jump to specific sections within a video that might be of interest to you. We're also beginning to use what we call training indicators to help you determine if an event or material applies to you. You'll see them in the description of a course, and some examples are of what training indicators represent: benefit categories, clinical and documentation examples, billing types, topics, or if the event is part of a series. We do have a page on our website that defines those different indicators for you if you want to find out more. On behalf of myself, all of our panelists, and the rest of the provider outreach and education team, We want to thank you for your participation today. We know you're busy and you have options during your day, so thank you for choosing to spend part of it with us. We hope you join us for future education, and we look forward to your survey feedback. You may now disconnect.